Yeah, so maybe we can start rolling and then let people join as they come. Thanks, Marty, for agreeing to talk today at our medicine rounds. We've been discussing over the past months and years about some of the nuances of our current DKA order set and what we see at the bedside as a consequence of the current model. And I think it's really timely, again, that you've done this deep dive into what works and what maybe could be improved upon, and the more of the stakeholders on the physician side that we have involved in the conversation, hopefully the better we can make it as we think about potentially adjusting things. So appreciate you talking to all of us and spending the time thinking about this.
Sure. Thanks. So as you highlight, Alexis, this is sort of, most of you knows me an intensivist, an internist, do some things in operations. I'm definitely not an endocrinologist, although I did spend 2 summers doing research on insulin signaling. So, take that from where it comes. I'll say my other conflict is that, I've been called probably a dozen times on a Friday, Saturday, Sunday night in the last couple of years as the chief of ICU saying, there's a patient in the Centenary Emerge in particular on like 52 hours of insulin, you have to admit them to the ICU. And so my bias in all of this, I think, is that, well, you can maybe make the case 51 hours ago, the patient might have benefited by coming to the ICU, but in their 53rd hour, there's been zero circumstances where I felt that it was warranted. And so some of the sort of thinking work that I've done in sort of pursuing this question and stealing the endocrinology spot and your grand rounds sequence was because we've been using an operational lens to try and solve what I'm going to present to you that I think is a quality problem. And some of that work has been trying to push patients to different units just to get them out to the emerge, which I think is necessary. Some has been to spending, I'm going to say, like dozens or even hundreds of hours training nurses on the ward to run IV insulin, which, I think in most circumstances is not necessary. And so hopefully I can present to you some ideas that maybe change our focus on how we can better manage these patients and achieve outcomes for everyone that are more desirable. But I do have a bias in that, taking a patient to the ICU for 6 hours of treatment and then watching them spend 6 days there is not a favorite thing to do. So you can interpret my musings with that lens to see if it resonates with you. So I started by taking a patient, and this is not a special patient. In fact, it was the next patient I looked after. In fact, I inherited after thinking through this problem. So there may be some nuances to his situation that are different than an average patient, but I think I learned a lot by really breaking down, like hour by hour, what we did for him to think about different ways of improving the care. So this gentleman was just under 70. He was at our Centenary site on a Saturday. He had a laparoscopic surgery for hepatic flexure bowel cancer. The surgery went perfectly well. He did have, for whatever it's worth, that sort of maybe made his management a little bit more complex, which I think is, every patient has nuances like this. He had mild to moderate LV dysfunction. I think his ejection fraction was in the low 40s. He hadn't really had any heart failure admissions or wasn't particularly symptomatic. Beginning on the subsequent morning, so post-op day 1, which is a Sunday morning, the surgeon noticed a few things in the morning lab work. And that really was that the anion gap was 19. It had been 12 a couple days before. His bicarb had dropped to 11. The glucose really wasn't that high. It was 12. And did the usual surgeon thing and called the internist on call. I think to her credit, that internist had a look at the lab work and said, I know what the problem is, and said, I'm going to send ketones. And I think this is euglycemic DKA. Called the ICU doctor, who admitted the patient to the ICU in 35 minutes, right? The patient, the diagnosis of this condition was made relatively rapidly. They had a good differential that included more than just that. And the patient got transferred to the ICU. For what it's worth, the starting ketone level, I'll talk about that in a little bit, was 3, which is not particularly high. But it was what it was. And so to walk you through the next 12 hours of this patient's care. So this is now Sunday, about 3 p.m. The team started insulin at a low rate. They're worried this patient had a sugar that was only 10 or 12. of course, the diagnosis is euglycemic DKA. There's some data that suggests these patients are maybe more insulin sensitive than your average DKA patient, at least initially, in part related to their SGLT2 inhibitor. So on that account, they wanted to keep the insulin rate relatively low. So they started at 1 or 2. I think it was mostly 1. The 2s are just sort of like transcription errors that I took out of Epic. They were quite thoughtful, saying, listen, I don't want the sugar to go low and I have to give insulin. So they actually amended, which is difficult to do in our protocol if anyone's ever used it. One of the background solutions and instead prescribed D10 at a rate of 50 for the most part. And then our DKA protocol specifies that if the potassium is in the 4 to 5 range, which I think it was somewhere there. Yeah, 4.3, 4.2. You get normal saline of 20 kcal at some rate. And again, because the physician was worried about this patient's history of congestive heart failure, dropped the rate to the lowest of the selected options of 50 cc's per hour. So, on things went over the next 12 hours. While all of you were sleeping, this physician was up at night, making sure things were running well. The sugar stayed in the 10 range, never dropped too much below, never dropped too much above, which is probably pretty darn good. And then at 3 in the morning or 10 to 4 in the morning, again, well, hopefully all of you were dreaming, remeasured the ketones. And what you see here is that at 4 in the morning, the ketones had only dropped from 3.0 to 2.8, so not really much of a budge. So then we move into what I'll call phase 2 of this patient's care. Recognizing the ketones hadn't really dropped, they said, listen, let's push the insulin up a little bit. We're still worried about the sugar, so let's run it at 2 units per hour. Again, this is all off book, and I think quite thoughtful. Kept the sugar at 50 cc's per hour. And then what you'll notice too is that the potassium dropped to 3.7. And if anyone's familiar with our protocol, it's kind of annoying because if the potassium is between 4 and 5, you get 20 of kcal in the bag. If it's below 4, you get 40. And so what we commonly see is the potassium sort of oscillate between just above 4, just below 4. And so every 4 hours, the nurse is changing the bag. Anyway, so on they went. So that was part of the regular protocol, still kept them on a low fluid rate. And in this phase, now running insulin a little bit higher, the ketones drop from 2.8 to 1.2. You might state, we don't usually get ketones like this, and I'd say that's true. So I think this group, the team that managed this patient, was quite thoughtful at saying, let's measure the ketones somewhat regularly to see what's really going on. And the part I'm going to point out is that you see the last lab work on the right-hand column at 2 in the afternoon, the anion gap was 7. Yet the ketones still hadn't cleared. So we consider ketones of less than 0.6 millimolar to have cleared your DKA, so they're double that. But the anion gap is actually much under 12, which we consider resolution of DKA, but the patient still had active ketones. I think that's maybe relevant down the road when we talk about why are we seeing maybe recurrences and opening up of anion gaps in some patients, and that's because maybe the anion gap doesn't tell the whole story. And just to make the final point that the sugar remained identical, 10, never lower than 9.5. And then the last phase, what's characteristic about Monday is that we have a transition of care. And I think a different group came on to say, what can we do to maybe accelerate this patient's care? And so what that team did is they added long-acting insulin. Could only talk the endocrinologist into 10 units. We're planning to give a bit more than that, but we used long-acting insulin, even though we hadn't resolved the DKA piece at that point. We doubled the insulin, saying, listen, we're not really burning through the ketones. Let's double this to 4. But to make it safe, we added more dextrose. We kept the dextrose running, and then our sort of background fluid, we added D5 instead of just normal saline and potassium. We ran that at double the rate and did that until things resolved. And you can sort of appreciate that by my screen, I can't tell you, whatever, 5 in the evening, the anion gap was actually up to 11, but the ketones were down to 0.2. So we'd actually won at that point in time. We were under 0.6 for our ketones. Our potassium was still going down. If you notice, he's only on 20 of kcal, and that's, I think, quite common for our protocol to have the potassium continue to go down. And we were able to stop the IV insulin at that point in time. The patient already had Tresiba like 5-6 hours earlier. So we just put him on a sliding scale and away he went. And so I think that's our ketones. Our sugar, again, didn't change. We added more dextrose into the background. And so the way I sort of characterize this and reviewing it and thinking about it was there's really three phases to this patient's treatment. The first phase, when he was initially admitted to the ICU between 3 p.m. and about the middle of the night, I would say is pretty characteristic of what our protocol gets us for a patient that has euglycemic DKA. Namely, we think they're relatively insulin sensitive, their sugar is not so high, we're concerned about them making them hypoglycemic, which I think is a real concern. I think hypoglycemia is maybe the most important safety endpoint in some of these patients' care. But you'll appreciate that the ketone change, if you remember, I went from 3 to 2.8. So over those 13 hours, if you average that out, that's a ketone clearance rate of 0.02 millimoles per hour. So to think about that in other ways, you need 50 hours, that's like 2 days, to drop the ketones by 1 millimolar. And if you recall, like many of these patients we're seeing in the ICU have ketones, not at 3. So I think if we can do this data, it would have taken us 10 days to 3 times 2, 6 days to clear the ketones in this patient with this low ketone number. And you're looking at like weeks if we're just running relatively low insulin rates like this in general. And so one of the conversations I had with our consulting endocrinologist, and her thought was like, listen, these euglycemic DKA patients take like days to get better. And it's like, yes, because we're not giving them much in the way of insulin. Our sugar never budged below 8. We gave about 6.5 grams of dextrose per hour, and that's actually more than they would have commonly gotten from the protocols I mentioned. They added a D10 infusion instead of a sort of sliding scale of D5. And my suspicion, and just based on my experience, is that this is pretty typical of the way that our protocol and we as a group manage euglycemic DKA, which maybe is not as safe. I wouldn't describe it as particularly efficient. The second phase occurred between about 4 a.m. and the sort of early next day. They said, listen, we're not really clearing the ketones. Let's double up the insulin. So they did so. So on average, this patient got 2 units of insulin an hour. We dropped the ketones from 2.8 to I think 1.2. So 1.6 period. Again, our ketone clearance rate is 0.16 per hour. Still going to take you 6 or 7 hours to drop the ketones by 1. And if you did this the entire time, for a DKA patient that comes into the emerge that's got a ketone level of 5, 6, 7, 8, 9, 10, you're looking at a week or longer, certainly multiple days to actually manage this patient. In the background, they continue the dextrose at a relatively higher rate, as I mentioned. They're getting 6 grams an hour. And I would sort of, my commentary on this is that this is, I think, what happens to many of our patients once their sugar starts to correct into a more normal range. So they get into the sort of 10, 12, 8 millimolar range, and our protocol asks us to appropriately dose reduce the insulin, and we're actually not burning through ketones very efficiently or effectively. But again, they were able to keep the patient safe with the glucose over in the 9 range and the 10 for most of the time. And the last phase I'll describe as sort of the last couple of hours where the team doubled the insulin rate to 4 units per hour. If you sort of reflect on the guidelines, they suggest in fixed dose insulin rates of 0.05 to starting at 0.1 units per kilogram per hour. So I like to think of an 80 kilogram patient. So that's 8. This guy was 82 kilograms, I think. 8 units an hour to start. And then once you get into sort of I'll call it a normal glucose range, so somewhere in the low teens and single digits, to drop that rate to 0.05 units. So 0.05 units would correspond to 4 units an hour, which is what we gave him here. As well, I think on top of that, we gave 10 units of Tresiba. So in that 3-hour period, the patient got like 22 units of insulin. The same that he got in the prior 10 hours, and the same that he got in the prior 13 hours prior to that. We burn through the ketones. We drop them 1 millimolar over that time, so 0.3 per hour. It'd take 3 hours to burn through 1 millimolar of ketones at that protocol. And again, the guidelines suggest we should be targeting a rate of 0.5. We recognize this is maybe a more challenging patient because of the normal-ish glucose. But to do so, we kept the sugar within a good range. It was still 10. But in doing so, we have a lot more dextrose in the background to support and give us the room to give more insulin. And I think this type of approach likely has benefits for both us and our patients in the future. And I'll sort of expand on what I mean by this and how we could accomplish that. So my improvement framework for this type of work involves for the 5 A's of healthcare. It's not really a quality improvement framework, but I think it's helpful to think about this. So starting the top left, my sort of hope and aim would be to improve health outcomes. And if you sort of translate this to DKA management, I would say that's faster resolution of DKA. I think that's also to reduce the rebound phenomena we see either in glucose or ketones that occur sometimes, and to in particular avoid hypoglycemia. You can maybe avoid hypokalemia in that as well. Moving to the right, this is maybe my background as sort of an operator. Are we able to reduce costs? And by reducing costs, it allows us to spend money on other things, more important things than wastage. And so to do so, that would be avoiding ICU admissions, avoiding prolonged periods of boarding in the emergency department. I think importantly, decreasing the total length of stay in hospital for these patients. And lastly, if we can reduce their readmission to hospital, I think those all stand to make substantial differences in cost reduction for these patients. Translating to the bottom right corner, when we focus on provider experiences, I think many of us often wait a couple of hours for lab results, and that can be challenging and problematic. If we can reduce that, that would be, I think, encouraging for our clinical teams. I think many times there's ambiguity on the roles. So, there's often an intensivist, an internist, and even an endocrinologist involved. And you've got sort of 3 chefs trying to stir the broth. And each has, I think, motivations to do the right thing, but you kind of need one person steering the ship so it stays in a consistent direction. I think we can reduce the ambiguity in that may help streamline some of the decision making for these patients. Additionally, these patients get multiple transfers, so they're think about who their MRP is. So they start in with an emerge doc as their MRP, then there's often an internist that sees them. The ones that end up in the ICU, there's an intensivist, and then they tend to get better in 6 to 12 hours, and then you have another internist on the ward, followed by an endocrinologist that sees them. And so there's often multiple transfers involved in this. I think if we can streamline this, the number of consults we see goes down, which maybe for those looking to pay their mortgage is not the best thing, but I think for many of us picking up patients, that can be particularly helpful if we're not being handed off MRP status in particular, not just sort of overnight transfers of care. And lastly, there's sort of some ambiguity that I've heard in speaking to others on, which patients should be referred to which service. I think all would agree that having an endocrinologist involved is really valuable to these patients' situations. But the one that comes up more commonly is which patients should come to the ICU or involve the intensivist for support. Translating to the bottom left, if we think about what the patient experience may be or ways we can improve the patient experience, certainly if you're in the emerge on IV insulin for 50 hours, that means you're getting an AccuCheck 50 times. And not only does that hurt if you've ever had it done to yourself, it also prevents you from sleeping. You're being woken up every hour to get your finger poked, and that's not fun. If we can drop this, if we can accelerate their care, drop the number of AccuChecks we're doing, I think that stands to improve the patient experience. This is all my sort of frame of reference. I think most patients, when I've spoken to them, not that they don't think the care in the emerge is ideal, they appreciate it, but being a patient in the emerge is not the same as being a patient in an ICU or a ward, where it's a bit more private, the beds are more comfortable, et cetera, et cetera. So there's some value in reducing emerge boarding. I've framed this as reduced length of stay. I think for patients, they would probably in their language say, just get me home, right? And so if you're staying longer in hospital for no particular reason, they would all rather be at home or in a different environment than the hospital. And if we can reduce venipunctures, again, if you're on an IV insulin drip for 48 hours, you're getting 12 or 13 venipunctures. If we can make this 10 hours, you're getting 2, maybe 3. And lastly, if there's means of us promoting equity, I would argue that one of the patients I had this week has ketone-prone type 2 diabetes, which we know is a race-related phenomenon, also known as flatbush diabetes. Are we able to tailor treatment more to the underlying condition? And this, I sort of highlight the different subtypes of DKA that we see, whether it's flatbush diabetes, whether it's euglycemic DKA, or sort of what we typically see in a type 1 diabetic patient. I think there's a suggestion that there can be referral biases depending on which patients present, and if we can be more structured and objective in what those are. And lastly, many of the patients I think that you and I've seen that have type 1 diabetes tend to be marginalized. They have higher rates of substance misuse than others. And so I would argue that they're an equity deserving group that should have the focus on their care that we can devote to it. So I think these are the reasons why I want to sort of pursue this. What am I doing here? There we go. And this is what an AI is. that looked at the number of finger pricks these patients are getting can often be quite debilitating. And the hope is to go from something where there's 50 of these to something where there's maybe 10 of these. I think that would be a positive outcome. And I say this because I don't think it's totally benign, these things. So on the right is a picture from the Lancet of a patient that albeit had an amputation of his finger related to the frequent, related to an infection and necrosis of his digit related to the frequent checks. Interestingly, the suggestion is if you run out of fingers to start using the thinner eminence, which I've never used before, but apparently it works just as well. So moving on, I just want to sort of highlight a couple of good practice statements, and I credit Jesse Delaney for sort of wanting me to sort of re-review this. So just that all ketoacidosis is not DKA. We see starvation ketosis, we see alcoholic ketosis, and other things. So don't just think that all ketoacidosis is DKA. And furthermore, I think most appreciate this, that all acidosis is not ketoacidosis. And so as often we're seeing patients with sepsis, another thing that may present with similar sorts of laboratory findings, high glucose, low in acidosis to keep in mind. I won't go into sort of the mechanics of measuring beta hydroxybutyrate versus acetoacetate and how the dynamics change as the DKA illness evolves. But I think there's even more into to that as well. That's somewhat interesting. The second good practice statement is that the mortality from DKA now is relatively small. So before the days of Banting, Best, and McLeod, mortality of DKA was over 90%. I think nowadays one would sort of throw out a number of about 2%. And I think our experience would be that it's not really the DKA itself that tends to drive the mortality. It tends to be sort of a contributor or bystander from another serious illness that precipitates a DKA. So really think about that if we're really focused on just normalizing the sugar and the ketones without being really conscious of what's driving this for the patient, sepsis, MI, other intoxications, other serious conditions, we may not actually improve the overall outcomes for patients. So that's my second good practice statement. And the last is that if we're going to develop a revised order set for managing DKA, recognize that this is a backbone, that it's not dynamic, and it responds to predicted physiologic and pathophysiologic changes in a patient as their illness evolves. But I'm going to say at best, it gets 75% of the decisions in the right direction. The problem is we don't know which 75% that is. So we really need focused clinicians using their experience and attention to figure out which 25% of the decisions this protocol is making wrong, and then what to do about it. So I think those would be my three messages that'll come before and after this discussion to not lose sight of. So, in all of that, what strategies can we use to sort of make this a little bit better? And the things I'll highlight are, number one, to focus on ketones and not just glucose. Second, that our current protocol is quite reactive rather than proactive. So what I propose is weight-based fixed dose insulin. Again, a liberal use of dextrose. I think none of us have ever seen a patient that didn't require lots of sugar at various times to keep their sugar up before their NN gap closed. And so why not use it earlier or more aggressively? This gives you some room to continue and preserve your insulin dose. I think there's an opportunity to standardize the fluid content, mostly related to sodium and potassium, as well as the rate, and quite honestly, make it easier for the nursing staff and make it easier for us to be able to amend it if we have to adjust up or adjust down, because right now that's not really an easy thing to do at the moment. On that note, making the protocol simpler. So making it more complex, I think you have to if you're going to make it more complex, you have to appreciate that you're making a dramatic difference, because complexity is going to make it harder to follow, introduce more error, and maybe not achieve the outcomes you're looking for. So I'd argue for a simplification. As well, I'd also argue for we have two protocols now. There's like a emerge one, and then there's an ICU one, but they're like identical. So what happens is that when I show up and I order the ICU protocol, and Mayo's ordered the emerge protocol, they interact. And so the lab work that Mayo's ordered is every 4 hours, and lab work I've ordered is also every 4 hours, but they're sort of sequenced every 2 hours. And so typically when you get sort of double the number of orders present, none of them get done. So what I'd argue is that we need one protocol that gets started in the emerge by the emerge doc. But then when either I come in or Alexis comes in as the internist in the emerge, that still keeps running, and we don't amend anything because it's actually just agnostic to whatever the location is or who the admission status of the patient. And it continues until they're off and better. Well, I'll argue for clear referral criteria to the ICU or for having a critical care physician involved. Clear roles and responsibilities for MRPs versus endocrinologists. And I think I'll highlight that to some degree. I think we could do better by having objective endpoints for completing treatment and then hard encode how we transition patients off IV insulin. And one of the strategies to do so will be to use long-acting insulin from the inception. And I'll explain to you why I think this will be helpful. And then lastly, to have some amendments to cover euglycemic DKAs. We're seeing a lot more SGLT2 inhibitors. And so I think all of us have seen this condition much more frequently in the last 5 years than in the 5 years prior to that. And probably that will continue as these drugs get rolled out further. So, did I skip something? No. So my first point is that DKA is about ketones and not just glucose. So on the left panel is our admission lab work that's done. And to give credit to the lab, they've been able to add a beta hydroxybutyrate analysis assay to our armamentarium. So beta hydroxybutyrate is probably the better ketone to measure. If you're doing urinary ketones, you're getting acetoacetate, which it's probably not the ideal one, but at least you can measure it and identify ketones. But what doesn't occur is we don't measure it actually ever again. And so to measure beta hydroxybutyrate or your ketone level again, you have to actually go off script, find the assay, and send it. And I'll sort of humorously counteract this with some of our friends and colleagues that are into ketosis-based diets and whatnot. Like these guys are measuring their ketones like 4, 5, 6 times a workout. So they're off at CrossFit with like lamb chops hanging out of their mouth just to maintain ketosis. And yet we have an ICU patient in an ICU with a life-threatening condition called ketoacidosis, and we're not measuring their ketones. And so, to reflect back on the patient I presented to you, and the time he's in the ICU, we measured his glucose 24 times, and we measured his ketones 3 times. And I would argue that in most patients, we measure them 0 to 1 times on average. So I'll make the case and the point that maybe we should be measuring ketones more often, and then we can focus on the ketosis and how we're treating it a bit more in a directive way. And to maybe say that focusing on the glucose is maybe not as critical, what I'll present is a paper from Ronaldo Bellomo's group. So those of you that know Ronaldo, he's the most cited ICU researcher in the world from the George Institute in Melbourne. And they took about 200,000 ICU admissions between Australia and New Zealand between about 2000 and 2013. And of those 2,000, I think 8,500 were for DKA or involved DKA. And their database pulled during the first 24 hours, and I guess this is related to sort of constructing an Apache or an severity score, both the highest and the lowest glucose in the first 24 hours of admission. So when they sort of isolated that on the 8,500 DKA patients, what they learned was that sort of predictably, if your highest or lowest glucose in the first 24 hours was under 10, they normalized that at 1. If it was higher, your risk of hypoglycemia got lower. And as you got further away from 10, so if your highest or lowest glucose was 40, your risk of hypoglycemia in that admission was 20% of what it was if your highest or lowest sugar was under 10. And that makes total sense. Like the more glucose you have, the less likely you're likely to have low glucose. Somewhat similarly, your risk of hypokalemia, for the most part, exception being in the teens, went down as your glucose went up. And this is a bit surprising because you can appreciate that patients with higher glucose need more insulin, and more insulin will drive more hypokalemia. But in general, the trend was to lower rates of hypoglycemia if your glucose was preserved at a higher than normal, what we call normal level, through the first 24 hours of your ICU stay. These are all ICU patients mentioned. Same story for hypoosmolarity. The more glucose you had, the less risk of having low osmolarity during your first 24 hours. And lastly, the story is a little bit different for hospital mortality. So again, normalizing a normal glucose of under 10 to 1. The lowest mortality for these patients was in the cohort where their sugar was in the teens during the first 24 hours. And then it sort of progressively increased from there. And so, if your sugar was 6, your highest or lowest sugar was 6, or your highest or lowest sugar was 42, your mortality rate was the same. So it sort of tells me that maybe the glucose isn't as important. I think avoiding low glucose is relevant. And when they plotted this is a plot for the highest glucose. They have a similar one for the lowest glucose in the first 24 hours. the mortality signal or bad event happening shows a relatively stable pattern if that sugar's in the teens, somewhere between 10 and 20 during the first 24 hours. And as you deviate from that, either higher or lower, the risk of bad outcome starts to increase. So having a lower sugar than 10 and worse as you get lower increases the risk of a bad outcome. And having a sugar higher than 20 and progressively higher than 20 also increases the risk of bad outcome. You can appreciate from the plot, there's a lot of variability here, but it's been a relatively consistent finding. And it tells me that maybe aiming for normal glycemia in the first 24 hours should not be the target. And so translating this to SHN, how do we measure ketones? Well, guess what? If you've looked around the units and you see the new glucometers, they say glu/ket. So they actually have the capacity to measure ketones. The difference is they need a different strip. So, my sense is that we probably only need to do this in the ED and the ICU only for these patients. The results can be populated into Epic right next to the point of care glucose measure. And then if you're thoughtful about this, getting back to my point of, pricking the finger of these patients quite frequently, if you can prick it once and get a good little drop of blood, and you have two machines handy, well, you can tap it once for glucose, take the other machine and tap it again for ketones. I say that because it takes, 15, 20 seconds to read each one. So it's hard to sort of flip the strips in the same device pretty quickly and not have that blood dry. But these strips are $1 in general. And so I think this is a feasible opportunity for us to try and leverage, given that we magically bought glucometers ketones. And this is where I think it may come help us. And I've sort of outlined a couple scenarios. I'll only review scenario 3. And this is a setting where, we see a patient and they start with a glucose in the 20s or 30s, and it starts to get better. And we start feeling good about ourselves. The glucose is getting better. And our reaction typically, and it's built into the protocol, is that we drop the insulin rate. But I think you might think about that decision a little bit differently if you had an hourly ketone measure paired with that. So if you start seeing the glucose decline, but the ketone's not really going anywhere, are you going to want to drop the insulin rate as quickly, or would you have a different time course? And my argument would be that you'd actually increase the insulin, maybe keep it the same, but add more dextrose in the background to support not metabolizing through the glucose so frequently and allowing you to maintain your insulin levels prescribed to metabolize the ketones. And I think this is a scenario that, particularly as we get on in our protocol, that we may be missing and what's sort of dragging out the dose of insulin so long in many of these patients. Moving on, so we give little amounts of glucose. The top panel is our current glucose protocol. So it starts by giving you a little bit of glucose in the background of dextrose of 1.25 grams. It maybe goes up to 6 grams. And where we sort of get stuck is that we started a good insulin rate. This is a top right panel of 0.1 units per kilo per hour, and I agree with that. And then once you get to what they consider the target sugar of 10 to 14, the protocol tells us to drop the insulin rate by half. And that probably is also what we should do. But it's actually happens again when in an hour your sugar's still in that range. So it's 11 and it stays at 11 the next hour. Well, you then drop the insulin 50% again. And when it stays the same the next hour, you drop it 50%. So it actually rapidly ramps down the insulin. I think this is a byproduct of just how the protocol is written. It was meant to say drop it 50% and then hold it, but it doesn't. And so this is what happens. And then we add sort of middling doses of dextrose back as the sugar goes lower. And what I'm going to propose is that number 1, we include D5 with our background fluids. Number 2, as our sugar goes lower, we add increasing doses of D10. So in this circumstance, we're giving quite significantly higher doses of dextrose, which will let us run our insulin higher for longer. And furthermore, rather than holding insulin before sugar level below 4, we sort of give a bit of a buffer. I propose 6. I think you make a case that holding insulin and being less aggressive at a sugar level of 8 even might have some merits and maybe something that's worth studying or talking about in the future. If you got questions, just holler them or put your hand up, because I can see I can't see the chat, but I can see hands. Additionally, looking at potassium, again, most of these patients are potassium deficient quite significantly. Our protocol oscillates between giving you 20 or 40 potassium, depending what your potassium is at that moment. What I'd argue is that we can make this simpler and just give 40 potassium. That's what many protocols recommend. Start at a higher level. Commonly potassium, it always starts high, but it never stays high. In fact, so the biggest problem actually is low potassium in these patients, and you can lose hours and hours of IV treatment, insulin treatment time by having to hold IV insulin. The maximum we can give is 10 milliequivalents of KCl an hour. So like if you have a really diligent nurse, you can maybe get those 4 bags of 10 milliequivalents of potassium in over 5 hours. And then you got to send a venipuncture labs after that. So you can lose like 8 hours of IV insulin treatment just because the potassium gets a bit low. So by getting ahead of it, hopefully we're
Marty, I think Erin has her hand up.
Oh, I missed that. Erin, yes.
Oh, hi. Thanks for your talk, Marty. I agree with what you're saying. I just wanted to add, I don't know if other people have noticed this, but I've had patients where their anion gap starts to open back up or their sugar starts to rise while on the insulin infusion. And the protocol doesn't seem to allow you to increase the rate of the units of insulin per hour once they have dropped.
Right. I've seen the same thing. And my hypothesis is 2 things. One is that there may be subtle holds of insulin that you're not appreciating because either the sugar's gone down too fast or there's a potassium problem. And then second is that, the way the protocol is built, it's actually built on a PDF. It's not actually an order. So you can't go in and adjust the rate of insulin yourself because a PDF is not editable. And so what we're looking to do is to actually hard encode the 1.1 unit per kilo at the high glucose and the 0.05 as hard orders that you can then go and say, actually, I want back 0.1 because the anion gaps open up again. And I think there's another strategy we have on top of that I'll explain in a second that may help a bit more with that same problem that we see.
Thank you.
So yes, what we said is exactly right, and seeing the same thing. So I guess my point with this is that we add more potassium and that you don't lose time by having to hold insulin. And the second thing is that as long as the patient's not vomiting everything else at testing, it's way more effective and faster to give it enterally. Like you can give 80 milliequivalents of KCl orally in like 10 minutes. And it takes, as I said, 4 hours to give 40 IV. And what I'll point out is that our sort of standing rate of IV fluid with 40 of KCl at 250 an hour, you're actually getting 10 milliequivalents of potassium every hour on just the background rate. So we may have to be a bit more attentive to higher potassium, but as I said, I've never encountered a patient after the first couple of hours that we haven't been giving potassium to in general, and it's low potassium that seems to be more the challenge. And lastly, speaking about fluids, so our protocol's on the left. So the Emerge sort of typically does a phase where they select a 2-liter bolus of saline or ringers. And then one of the challenges we have is there's like 3 separate orders for fluids. There's one with normal saline, there's one with normal saline 20 KCl, there's one with normal saline 4. So you have to adjust all of them if you want to change the fluid rate. And the buttons that were provided range from 50 to 150 cc's per hour. So if you look at this over a 12-hour period, you're getting at most 3.5 liters. If you look over an 18-hour period, you're getting somewhere between 3 and 4 liters. And we know that the water deficit in these patients is often up to 8 liters. If you take the guidelines that come from the UK, they give sort of a prescription that gets you up to 5 or 6 liters over the first 12 or 18 hours. But the way they present it's really difficult. Like I have a hard time writing an order from this or telling a nurse how to do this, where it's like, give the first liter over an hour, give the second liter over 2 hours. Okay, so that's 500 cc's for 2 hours. Oh, and then the third liter you also want to give over 2 hours. So like keep running it at 500 cc's for 2 more hours. And then now we're on to the 4th liter. We want to do it at 250 an hour for, I guess, 8 hours. And it's just really cumbersome to actually be able to prescribe that. And so as a simpleton, I would just say, run the damn thing at 250 cc's per hour. We're going to get to the same amount. And that way, if, Erin's concerned that she's given too much fluid because the patient's maybe got some LV dysfunction or they're being crackly, you just have to change one order and drop it to 50 cc's or 100 cc's or whatever you want. It's one order you can adjust, or vice versa. If you think you're behind, you can actually up that. Or if you want to change the fluid, you can actually just change the content of the fluid. It's not like 4, 5, 6 separate orders. You have to sort of figure out, are we on the 5th liter or the 6th liter? And do I have to, delete 7 and 8 liters from the order? So the suggestion is to make this simpler and a fixed rate dose that gets us to the same endpoint. And then moving on to sort of looking at sort of roles, my impression is that the MRP needs complete oversight of these patients. One of the challenges is that these patients never get better over someone's single shift. They don't come in at 8:05 in the morning and get better at 16:42. So inevitably these patients need to be signed over, and I think all the physicians involved in their care need to be quite attentive. And I mean, I remember as a resident, the really nerdy ones like Mona used to be like, here's a piece of paper showing all of their potassium, bicarbs, glucoses over the last 12 hours, and then they sign over to you a table, and you just filled it in overnight, and then they were usually grateful the next morning if you did so. I say that because Mona and I were med school classmates, and she was our gold medalist, I think. But again, I bring back my point that this, even if like the most well thought out protocol is still going to be wrong a lot. And so you have to be really attentive to these patients and tinker. I find that satisfying in many circumstances, but it does take time and attention. And thirdly, I'd say that, you know, there's a GIM exam that hasn't included a DKA station. And for that, I'm grateful that Jesse Delaney was in my study group and got me through it. But it means that this is in the scope of any of our internists, our endocrinologists, or ICU physicians. And so what I'll argue is that we could really utilize our endocrinologists maybe best by stabilizing the patient and supporting their transition home, rather than sort of tinkering with like start and stopping IV insulin and different rates that. So, and I think it's appreciated, but I think it leads to role clarity. And I ask myself, is part of the reason we see this most commonly on the weekend at centenaries because our coverage models are different on the weekend, and I don't blame anyone for not being there 12 hours a day on a weekend. But my sense is that the number of adjustments that are happening for patients is less on a weekend because our staffing is reduced at that point in time. And lastly, for the question of who should go to the ICU, I'll just say the usual reasons you refer someone to the ICU: they're hypotensive, they've got a big MI, they're septic. I think in these cases, if they're on uric or on dialysis or have heart failure, these are all patients that should go. But then sort of more simply, rather than putting like 6 different acidosis criteria, like a bicarb of this and a ketones of that, like at the end of the day, if the pH is less than 7, that encompasses almost all of these patients. And similarly, it's not so much the high potassium patients that I worry about, it's the ones that are low coming in, because typically you'll need a central line to replace this and a cardiac monitor to do so aggressively. And usually a high potassium is not a lasting problem. So I think these are what I'd suggest as sort of ICU criteria. And what does this all mean? So there's a guy that was from the West Midlands in the NHS that did a quality improvement project about 10 years ago now. And they started off, these are all ward patients and none that went to the ICU, I should sort of highlight. But on average, it was taking them 22 hours with a range up to about 28 hours to correct the DKA in their cohort of patients. And they started doing some PDSA and sort of doing some audit and feedback. And eventually they moved things and adapted a protocol that did 5 things: fixed dose fluids, weight-based insulin, regular ketone measurement, involving a diabetologist. The 5th one I always forget. Anyways, and they got this from 22 hours down to 7 hours. And the range, if you appreciate at that time, was really tight. So 7 hours, the high, like 95th percentile of 8.7. And to me, this is dramatic because I highlight this, that I started thinking about this as how do I solve an operational problem with quality? Well, it's true, a patient shouldn't spend 22 hours in the emerge getting this care. And it's not only just in the emerge, it's actually in the highest acuity beds in the emerge, which are at a premium. But if you can make this 7 hours, do they even need to come to the ICU? Can they just get all their care in the emerge and transition out to the ward directly? And I think this is where the opportunity lies for us. And I think this group demonstrated that with similar principles, and I think we can achieve it. The last part I'll sort of focus on is, how do we get patients off insulin? And right now our strategy is if their anion gap is under 12, if they can tolerate a diet, and then you give them long-acting insulin, and then you wait 2 hours. And what I'd say is we can hard encode this. Again, looking at ketone measures automatically if they're under 0.6, and the patient's not vomiting everything everywhere, you can transition them directly to a sub-Q slotting scale because we're already going to give them long-acting. And I'll highlight the rationale for that in a second. I will point out the patient I inherited on Sunday night, Monday night, Tuesday morning. He got fantastic care in the emerge by the internist. In fact, I heard he's an endocrinologist, which may be why it happened that way. Within 10 hours, his anion gap closed. 6 hours later, his anion gap was still closed, but he had a sore throat. Eat. And so the internist called the intensivist saying, he doesn't really want to eat. He still needs IV insulin. Take him to the ICU. And that's why he got admitted to the ICU, because his throat was sore. And the 24th hour of his care. Insane. He's still in the, actually he just left this morning. So anyways, Again, to go back to what our traditional criteria are, the problem is that it's actually 4 different decisions in one, and they're all spaced in time. So you have to think, has this DKA resolved? Look up the labs, wait for an ANA and GAP every 4 hours. Then you have to say, well, are they eating? How much do they eat? What did I even order the diet? And then you got to give them long-acting insulin, and then you got to wait 2 hours. And that's like 8 hours of steps. Again, that spans someone's shift. I don't think we do that efficiently. And then the other situation is that like our long-acting insulin defaults to 9 a.m. or 9 p.m. So if it's like 2 in the afternoon, you got to wait 7 hours just to get long-acting insulin at night. And then hopefully at 11 p.m. you can stop the IV insulin, but who's up at that hour to actually want to do that? So I think we have really strong challenges of transitioning off IV insulin, and we can hard encode this to make it safe. And so what I'm going to propose that we give patients a weight-based dose of glargine at inception and continue every 24 hours. So the long-acting insulin is already done. You don't have to worry about that part. As long as they're not vomiting, you can just stop the IV insulin and put them on a sliding scale, and they're through. And I'm going to sort of, hopefully there's some smart endocrinologists that can tell me sort of this a bit more specifically, but part of the reason Aaron brought up the role of sort of ANA and GAPs opening up again and glucose getting higher. And my thought is that this is a chart of insulin activity over time by different types of insulin. And this sort of 2-hour overlap comes from an era when we used NPH as a dominant longer acting insulin. And so if you look at the activity of NPH at the 2-hour mark, it sort of gives you this level. If you take glargine or even like Tresiba and see where they achieve that same level of activity, well, for glargine, it takes 4 hours to get that same activity level of the insulin. So maybe it's actually we're not waiting long enough to transition off IV insulin in these circumstances. And for things like Tresiba, they never achieve the same level. So you'd actually have to, increase the dose substantially and wait even longer, 6 or 8 hours to achieve that effect. And so, ask if part of the reason we're seeing ANA and GAPs opening up again in some patients because we actually are not giving either enough or enough overlap for these situations. Someone can sort of inform me. This is just my musings. And the last sort of point I'll make is that there are certainly protocols for managing DKA that are just sub-Q insulin. So this is from a health system called the Kaiser Permanente system, and one of their hospitals decided they're going to try and develop a sub-Q insulin protocol, and they did. And so 80% of their patients get sub-Q insulin exclusively. Their number of ICU admissions in the period compared to over time and also compared to their peer hospitals dropped by almost 60%. And the patients' readmission rates, surprisingly, because they didn't actually make this a sort of hard thing, dropped by 50%. So the thought is that by focusing on managing your DKA with sub-Q insulin, you have better overall control of your diabetes in the period thereafter, and their 30-day admission was dramatically less. And that's a big and significant outcome. And their protocol really was simple. Like it really is not complicated. They took 0.3 units per kilo of insulin long-acting upfront. So an 80 kilogram adult, that's 24 units of glargine. And then every 4 hours, if your sugar was more than 14, you got 24 units, the same dose of ultra short-acting, so Lispro. So 4 hours later, if you're above 14, another 24 units of short-acting. 4 hours later, and on until it went under 14. They didn't even measure your ketones. They didn't even measure your AccuCheck. Just when your sugar went under 14, you stopped. You got your long-acting ongoing and a sliding scale. It was really quite simple. They got a crap ton of fluid, I'll say. Like 625 cc's of ringers an hour, plus 150 cc's of potassium containing solutions. They're getting like 800 cc's an hour for 8 hours. So big doses of fluid. And when the patient transitioned to the ward, because about half their care was managed on the ward, they gave the exact same long-acting dose of insulin every 24 hours. They just gave 2/3 of the dose of Lispro, and again, until your sugar dropped below 14, and then you were done. And they had no increased risk of hypoglycemia. Length of stay was the same, and said ICU admissions were down by 57%. So I'm not going to advocate for like using sub-Q insulin exclusively, but I think it tells us that you probably don't need IV insulin on the ward. Second is it gives sort of some rationale for using long-acting insulin up front, and that it's safe and effective. And so the last ADA guidelines for DKA were updated in 2009. Since then, there's been about 6 studies looking at giving long-acting basal insulin from inception for DKA. And each of them showed safety, i.e. there was no risk of hypoglycemia higher, there was no risk of hypokalemia, but depending on which study you look at, there were some positive outcomes. So it's at least as effective and safe. And in many circumstances, there were decreases in lengths of stay, IV rates, ICU admissions, et cetera, et cetera. So the commentary from this group of mostly pharmacists who, I like because they're quite objective and detached from part of the heat of this, were that given the significant congestions in hospitals and ED boarding, it's likely patients could receive early basal insulin, have DKA resolution in the ED, we're talking about, avoid ICU transfer, and even potentially hospital admission altogether. And so I think this is really a encouraging strategy for us to do. So to sort of finish up, I ask myself again, what does better treatment look like? And this is sort of with a lens to developing a quality improvement project, looking at different outcomes. So again, it's looking at clinical outcomes like cardiac arrest and ICU transfer, reducing the risk of hypoglycemia. I think at different thresholds of hypoglycemia, I'd argue 4 is probably pretty dangerous. You might even want to measure something at like 6, 8, or 10. Again, avoiding hypoglycemia. For the ED team, looking at the time they're making a diagnosis, how long it's taking them to start insulin. For the treating team, whether it's internal medicine or ICU, how long is it taking us to resolve this? How long is it taking us from resolution to get off IV insulin? What are our correction rates? How much insulin are we giving? Can we measure lengths of stay either in ICU, emerge, or hospital? Are we having to give insulin on the wards at all, or how much? And are we seeing drops in readmission? I'm not going to go through all of these outcomes again, but as I thought about it more, it may be worth reframing some of these to focus on some of these other pieces, including transfers of care and referrals. And lastly, I think there's a real strong desire from many in our organization to think about patient experience and equity. And can we reduce the number of lab draws and venipunctures? I mean, if you ever looked at a patient's hands that have gone through 50 AccuChecks over 50 hours, like they're beaten up. This is my patient today. And it's not a fantastic photo, but he's got lots of little pock marks on the tip of his fingers. And I thought it might be nice as a equity / patient experience measure to take photos of their hands and sort of identify what changes for these patients as a marker of who they are and their journey in our healthcare system. And if they have fewer prick marks at the end of their hand, that's probably a positive outcome. So to get there, I was going to say we need to amend our protocol. I actually think we need to just abandon what we have for DKA. As I said before, it needs to be setting agnostic. I think we can develop it internally and ask our CHC partners if they want to join. And there's a lot of interest. Just say, if you developed the original EPIC DKA protocol, you have no friends. It is like the least loved piece of hospital order sets I've ever that we should include some amendments for euglycemic DKA. I think it's really not a lot of time for an EPIC builder. We would love to have champions from the eMERGE and GIM and Endocrinology help sort of support this and develop it. We're working on some validation of the point of care ketone measure and have a point of care person that's going to help us roll this out. We don't have all the fluids, so it's centenary. It's nearly impossible to find D5 normal state of 40 kcal, but I think we've solved that recently. And we do have an operational commitment, and that's if we can actually fix these patients early, we can extend their stays reasonably in the eMERGE, so you don't have to go to 2 or 3 units just to get over their hump. So I won't go through this. I'm happy to send you this, but I've broken down what our protocol is and how it can be sort of simplified, both for thinking about this. So for the nursing staff to say, like, how do I run through this? Okay, first think of the ketones. If the ketones are less than 0.6, you're done. You continue the long-acting insulin, you start the sliding scale, the orders are there, you drop the fluid rates to 50, you call the doctor and say the patient's done, they can go to the ward. If the ketones are still elevated, we think about potassium first. If it's low, you got to stop and give oral potassium. If it's normal, you keep going. And the third step is looking at the glucose and how much D10 are you adding, what is the insulin rate, and moving forward from that. And I think by having a linear progression for our staff to go through, we'll have fewer errors. And lastly, doing the same thing for euglycemic DKA, where you really you defer the boluses that are sort of come in our prescription. You count for their insulin sensitivity being higher, and you drop the fluid rate. So lastly, I'll just direct you to the UK Diabetes Societies that have guidelines from 2023, which I think are really thoughtful and helpful and sort of form the basis for a lot of these amendments. I think it's a really great document. And lastly, if you've got any thoughts, comments, like some of these ideas are a little bit radical, please send them to me, especially if you've got patients or patient stories that you think would help inform the process. And if you've got interest in doing this, I think there's there's a lot of people that want to amend the DKA protocol. And I think it's worth having a targeted group to help roll it out and get some excitement, because I think this would improve our experience treating patients and that of our patients as well. So I know I just hit time, but happy to entertain comments or questions. And I've included my email address. So if you don't know me, you don't know how to get in touch with me, which I don't think is a lot of people, please reach out in any way if you got any thoughts or comments on what I presented. Yeah. Thanks.
Thanks, Marty. It's Taryn Becker. Can you hear me?
Loud and clear. Yeah.
Okay, so I think I've heard some of this before, but just to sort of reiterate for the group, I don't think that these thoughts are radical at all. I think that they make perfect sense. And I think that, you know, if we took a vote, there would be very few people who are in favor of keeping the current DKA protocol. It doesn't work for most of us. It doesn't work for most of the physicians, the pharmacists, or the nurses. And as you say, you know, in the end, the patients suffer and the system suffers. A couple of things is that, just to sort of summarize and reiterate what you're saying, is that we are definitely focusing on glucose and therefore insulin as a result of glucose, as opposed to focusing on the acidosis and the ketoacidosis specifically. And so that's really just a change in the focus. Like, it's not, we still have the same goal. We're just changing how we're getting there. And we most likely would be getting there more efficiently by using this sort of an approach. The other thing is, it would be helpful, as you say, instead of using some sort of a PDF, if there was some way to sort of modify some of our, if possible, some of our requests for a given patient. The third thing is, just for the people who are still using the current DKA protocol, you're right that sometimes we have to override what's happening, but we can't do so in the orders. I have found personally that if you just put as a nursing order, like one of those nursing miscellaneous, please adjust insulin rate to X, like 7 units an hour or 10 units an hour or whatever, and then continue to follow the protocol at the next blood sugar reading, it actually works quite well because there's no way to do it within the protocol. So that's just a little pro tip.
Yeah.
Thank you.
Thanks for that.
Thanks, Marty. Appreciate you taking the time. Any other questions from the group? I think one thing, I would also add further to Taryn's point. I think, you know, in the discussion about trying to redo this protocol, baked into the protocol with the PDFs and the directives in the background means it's not very transparent what's happening at any given time. And simplifying the orders and actually having it relatively fewer orders that can be adjusted in real time explicitly by the physicians, I think just simplifies everything. And part of the care burden that, you know, Marty touches on in the 5 aims is it's a very high nursing burden, but not all of it is directly because of the care, although it can be. Part of it is created by the protocol itself. And the fact that we all have a different screen that's formatted differently in Epic. And so a lot of conversations happen over the phone where they don't know what you're seeing and you don't know what they're seeing. So the less of that ambiguity, I think, the more efficient the whole thing will run. Thanks.
Yeah, so I'll just say that, you know, there's potentially, if you really want to take this far, like there's definitely a big publication in this there's really not a lot of data looking at ketone focused DKA protocols. I'm not aware of any in Canada necessarily. It's that UK group that's the only one that's sort of done it as part of like a PDSA cycle. So I think there's an opportunity to test that as a thing. And it's actually not that difficult to flip what I've proposed back to ANA and GAP. So like if you're at Campbellford, they don't want to do ketone measurements, you can just, whatever it says ketone, just say ANA and GAP greater than 12 or less than 12. It's actually quite simple to go back to that. You're only getting it every 4 hours, but I think like there's probably a test in that actually to say, does this make a difference? I think additionally, there's a modest amount regarding long-acting insulin. I think there's also an opportunity to test different thresholds. Like, should we be using I got Sunnybrook uses, if the sugar's under 4, at the clinician's discretion, continue the insulin. Well, I think that's kind of dangerous. You know, can we use a threshold of 8? Would that be safer? And I think, you know, having to stop IV insulin when the sugar's 7 is not such a big deal if they've also got long acting on board, so you're not actually losing the whole time to not giving IV insulin for the period you're holding the IV insulin, because they've already had, 22 units of long acting earlier that day. So maybe it creates a safer environment. And the same thing goes to potassium. So there's maybe a test of that too. Any other challenges? Challenge me on this, please, because I said I'm not a thoughtful endocrinologist or otherwise. I've also eliminated osmolality just for those, like, who's ever looked at the osmolality trend? I mean, I'm sure there are people out there that have. I can't say that I have often. And for that reason, do you really need urea if you're looking at a calculated osmolality? So there's opportunities to simplify and make this a little bit easier that front. And again, if someone wants me to challenge on that, please do, because I think I've got one paper showing that it probably doesn't really matter. But that's also why we haven't included, you notice what's missing is a bolus of IV insulin. It's not included here. Again, it's sort of discouraged in pediatric populations, and the data shows it probably doesn't make a difference for adults. You're welcome to do it if you want. And the same thing would be for bicarb, right? The data says maybe bicarb under 6.9, but it's a maybe. So again, if you want to, you're more than welcome to do it, order it yourself. It doesn't have to be part of the protocol. So those are sort of the other things that sometimes get brought up. Awesome.
So maybe we'll let the group digest and bother you afterwards as the questions come up.
Yeah, I'm happy to be bothered and have thoughtful conversations. But my understanding is that the first time this has been trialed here is with our good colleague Josh Landy and Sue St. Marie a couple of weeks ago, where we talked about this over a weekend, and we got some of this implemented. And so if you also have a patient, like, I hate to volunteer myself, but like, send me a text or message if you've got a patient that emerged this weekend. I'm on service all week at Centenary. Like, I can sort of mock up these orders pretty quick, just de novo, because it's relatively simple that we can sort of move towards this even without the full protocol involved.
Thanks, Marty, for giving the talk. I think this was helpful.
You're welcome.
With that, maybe we'll close out. Thanks all for joining today, and hope to hear more about this. Hopefully we can continue to push from a even QI project perspective to try to roll this out comprehensively. And then justify.
There's a grant application that's open until December the 3rd that I think we should apply for.
Great. Yeah. And again, any who are interested in taking a role in this, a more active role, please reach out to us. Thanks again.